For decades, we've known that the most efficient way to increase health professional supply in rural areas is to train them there.
We have only 2% of residents training in rural communities, yet 20% of our population lives in rural communities.
So in 2017, the federal government said, well, let's make it easier for rural communities to build their own residencies.
Rural people in the U.S. are sicker, they are older. By 2037, there will be the shortage of doctors. In urban part, there will be shortage of 22%, and in the rural part, it's 33%.
The scope of practice of physicians in a rural community is broader because they can't refer as easily.
It really does attract people who have that sense of mission and purpose.
Being able to show through the data the incredible expansion of these residencies once they had technical assistance is just remarkable.
The initiation of my role with the TAC was really helping put together that roadmap and all the stages and the objectives that went along with it, which is still the infrastructure that we have then built the entire Technical Assistance Center on.
The Rural GME portal is our best tool as an advisor and as a TA center.
A Rural GME portal is the place that you can go to know what the next step is and how to get there.
The portal actually gave you a starting point for a lot of your policies, for evaluations, for faculty development.
It's always exciting to look in the portal and see what progress has been made by the grantee.
Also, it allowed us to kind of celebrate as we went that we were actually moving.
The fact that we have shown that you can develop rural residencies and teaching health center in places that you didn't think you could, that's innovative.
The portal provides connection to one-on-one relationship with an advisor that meets quarterly with each grantee.
The relationship that I had with my RRPD advisor was one of the most valuable relationships. He was at times a therapist, a counselor, a friend, and a colleague, and I would still count him actually as all of those things.
We are very focused on communities being the experts at what they do and needing to tailor each one to that community.
In our community, we were home to one of the first RRPD grant recipients. The icing on the cake is 7 of 8 of those graduates have stayed in our community. And in that process, they expanded access to care, behavioral health, opioid use treatment, and also recruited physicians who see patients as residents.
To launch a new rural residency program, it takes a village. It takes many different partners working together. Stakeholders, whether they're in the community or whether they're across the country, can help play a key role in getting these programs launched and launched successfully.
A lot of people in a big team have worked really hard in this for many years.
1 in 4 rural residencies has been supported by the Rural Residency Planning and Development Program. And what I love about what we're invested in, all of these partners and people, and certainly grant recipients, is that we are training the next generation to not shy away from complex or vulnerable patients.
The covert mission of the TAC has also been to disseminate the message that this is an option if they're thinking about trying to grow their program or have a new program in one of these communities. It's just really exciting.
For stakeholders at either a state or national level who want to get involved with the RRPD-TAC, it can be as simple as reaching out to anyone involved with the TAC and letting them know what their specific expertise or question might be. To other communities and hospital systems considering rural residency programs, go for it. It's going to benefit your community, it will benefit your hospital system.